Good afternoon, dear students. Now going to talk about care for patients with respiratory diseases. There is a significant increase of disease of the respiratory system in industrialized countries. They went out on third, fourth place among the causes of mortality of the population. Respiratory diseases are responsible for over 10% of hospitalization and over 16% of deaths in Russia. Pulmonology is a medical specialty that deals with diseases involving the respiratory tract. Doctors specializes in respiratory diseases known as pulmonologist, and nurses specializes in respiratory diseases known as respiratory nurse. Anatomy of the respiratory system. There are upper respiratory tract and lower respiratory tract. So you should know that it is nasopharynx, nasal passageways, pharynx, nose, mouth, larynx, trachea, lungs, bronchus, and diaphragm. The main term which we will need are respiration. We will name it the act of breathing. Inhalation or inspiration, process of air intake, air in. Exhalation or expiration refers to breathing out, movement of gases from the lungs to the atmosphere, or breathing out. And ventilation used to refer to the movement of air in and out of the lungs. Means combination of inhalation and exhalation. Regulation of the breathing. You should know that respiration is controlled by respiratory center in medulla oblongata in pons of brain. Chemoreceptors located centrally in the medulla and peripherally in the carotid and aortic bodies. These receptors are more sensitive to the CO2 concentration in blood. Characteristics of the respiration. If you need to describe someone's respiration, you will need to tell about their types of breathing, rate of breathing, depth, rhythm, and easiness of respiration. Normal breathing of a healthy person is effortless, automatic, regular, and without noise producing. We will call it as eupnea. Eupnea, normal, relaxed, quiet breathing, usually 500 ml per breath, and 60 to 20 breaths in a minute. And now more detail, let's consider all characteristics of respiration. First characteristic is type of respiration. There are three types, can be thoracic or coastal respiration, abdominal or diaphragmatic respiration, and mixed. Coastal respiration, in this case, main muscles are intercostals, and more typical for the women. This type of respiration more typical for the women. Another type is abdominal respiration. In this case, diaphragm will be the primary muscle. This type of respiration more typical for the men. and mixed respiration. The diaphragm and intercostal muscles simultaneously carry out the respiratory movement. We can observe this type of respiration in the elderly senile patient, in some pulmonary and digestive diseases. Next characteristic of respiration is rate of breathing. And we will describe it in breaths per minute. Rate of respiration is a number of full respiration. Pay attention that you will have to count complex of the inhalation and inhalation in 1 minute. And as we told, the normal rate of respiration for adult will be between 60 to 20 breaths per minute. There are a lot of factors that may affect the number of respiration. First of all, it's age of the person. Of course, the gender, emotions, changing in the atmospheric pressure when we exercising, changing in the external temperature, digestion, food intake and digestion, any disease condition, and some drug intake. Terminology to describe rate of breathing. Eupnea, 60 to 20 breath in a minute. Tachypnea, it's quick shallow breathing over the 20 per minute. Bradypnea, it's abnormal slow breathing less than 60 per minute. And apnea, it is temporary cessation of a breathing when there's no breathing for the short time, one or more skipped breath. Depth of respiration, as we told, normally remain at rest inhales and exhales about 500. If more than this quantity of air passes, we will name it deep respiration. If the quantity of air is considerably less, we will name it shallow breathing. Now you can see definition of hyperventilation, overexpansion of the lungs characterized by rapid and deep breathing. Main etiological factor is anxiety, depressive disorders. It is mental disorders that disorganize normal breathing and very often will lead to hyperventilation. As we know, the respiratory system has a close connection with the emotional state of the person, especially anxiety. Hypoventilation, it is the definition of hypoventilation, under expansion of the lungs characterized by shallow respiration. There's a lot of pathological condition causes which may lead to hypoventilation, or to one of them obesity hypoventilation syndrome, is known as Pickwick syndrome. Is defined as the presence of awake alveolar hypoventilation in the absence of another reason. Person with BMI more than 30 or even higher are at risk for obesity hypoventilation syndrome. Next characteristic of respiration is rhythm of respiration. It is intervals between every next respiratory cycles. To describe, we can use regular rhythm or irregular. As we told, respiratory center is responsible for our respiration. So in case of severe depression of respiratory center, patient breathing becomes arrhythmic or irregular. And we will name this periodic respiration. And there are several types of periodic respiration: Biot respiration, Cheney-Stokes respiration, Grokas respiration, and Kussmaul respiration. Kussmaul respiration very often we name as a terminal respiration. Now, more detail about these types. Biot respiration, characterized by rhythmic but deep respiration movements with long respiratory pause, with long apnea from few seconds to half of a minute. Now let's have a look at the scheme of biot respiration. First, you can see long apnea, pause in breathing, then regular and deep respiration. After a few respiratory cycles, we can see apnea again. And it's going to repeat over and over. Next periodic respiration is Cheney-Stokes breathing. It is waxing and waning of respiration from very deep to very shallow breathing, and with temporary apnea as like before. Now you can see the scheme of Cheney-Stokes respiration. After long apnea, you can see shallow breathing with increasing the depth of respiration, and then decreasing depth of respiration and apnea, and it's going to repeat. Grokas respiration or wave-like will be one different, because instead of apnea, when there's no any respiratory movement, we will see very shallow breathing. It reminds wave. Another type of respiration. Kussmaul, as I told, very often we name it terminal breathing. Very often we can observe it in case of acidosis in diabetes mellitus. And if compared with normal breathing, you can see that very deep and very deep and fast breathing. Next characteristic of respiration, it is easiness of respiration. Respiratory quality or character refers to those aspects of breathing that are different from normal effortless breathing. Two of these aspects are the amount of effort of patient must exert to breathe and the sounds breathing. So try to remember how to recognize the effort breathing. We need to observe two aspects: amount of patient's effort and breathing sounds. Usually breathing of a healthy person doesn't require noticeable effort, but sometimes it will be so visible. In this case, we will name this breathing as a labored breathing. Now, definition of dyspnea. Dyspnea is difficult labored breathing which accompanied by violation of type, rate, rhythm, and depth of breathing. Now you can see that in case of dyspnea, a lot of respiration characteristics can be evaluated. One of the type of dyspnea we will name autopnea. It is ability to breathe only in upright sitting or standing position. And as you remember, it is forced position which patient takes himself to get relief, in this case, relief in breathing. And now you can see two types of autopnea. Autopnea with all muscles relaxed in case of heart diseases, heart failure, and autopnea 2 with all muscles straightened when patient taking support in case of respiratory diseases. In a bit explanation why patient feels easy in lying position. Lying position causing the patient to have to sleep propped up in bed or sitting in chair. In this case, in sitting position, abdominal organs and diaphragm goes a bit down because of gravity, and it leads to diameter of chest increasing, and this allows more freedom for movement lungs, and patient feels better. Breathing sounds. Now we will talk about breathing sounds which you can hear without stethoscope. And we will talk about pathological breathing sounds. And you should remember the three types of pathological sounds: distance sounds, stridor, shrill, harsh sound heard during inspiration with laryngeal obstruction. This kind of breath sound we can hear in case of choking. Removed with continuous high-pitched musical whistling sounds. More better we can hear in expiration, sometimes on inspiration, and it says about bronchospasm, narrowing or partially obstructed airways. Bubbling sounds, gargling sounds can be heard when air passes through the moisture. It can be sputum accumulation, or blood accumulation. Now we will talk about main symptoms of respiratory diseases, and let's remember the difference between symptom or patient complaints and sign that can be detected by the medical staff. Now you can see the difference between symptom and sign. Symptoms, it's just the patient feelings, and it is subjective evidence of disease. A sign, it is objective evidence of disease, sign phenomena that can be detected by the medical staff after patient examination. And now you can see some examples. Pain or fatigue, it's are all symptoms because patient may tell us about these feelings. In contrast, bloody nose is a sign of injured blood vessels, can be detected by the medical staff. After last lecture, now you know that symptoms can be divided into main and secondary. Main symptoms, complaints, usually life-threatening and very pathognomonic for the disease. Secondary symptoms can be found in various diseases. Main symptoms, which typical for respiratory system: dyspnea, cough, hemoptysis or blood expectoration, and pain in the chest. Secondary symptoms: fever, asthenia, indisposition, or sometimes loss of appetite. Now the question is dyspnea. We can use another words to explain that, such as shortness of breath, breathlessness, but you understand that it is difficulty in breathing. So dyspnea is difficult labored breathing, which accompanied by violation of main respiration characteristics such as type, rate, rhythm, and depth. Like pain, dyspnea can be felt by the patient or it can be observed by the doctor. There are first two main groups of dyspnea: physiological and pathological. Pathological dyspnea can be divided into some groups with respect to the patient, according to time appearance, according to the violation of the respiratory cycle, and according the appearance mechanism. Let's consider more detail. Physiological dyspnea. It's just a compensatory reaction of respiratory system or considerable physical or emotional exertion. How to recognize it is physiological or pathological dyspnea? Of course, we should know the signs of physiological dyspnea. In this case, only breathing rate and depth will change. This type of dyspnea is short-term and passes themselves in 3-5 minutes and never accompanied with unpleasant sensations such as weakness, headache, tightness in the chest, or so on. Pathological dyspnea is caused by affection of different organs and systems, and first of all, respiratory and cardiovascular. More resistant respiration rate, rhythm, and depth disorders, and very often accompanied by unpleasant sensation. Now, types of pathological dyspnea. First, classification: subjective and objective. And as we told now, subjective dyspnea is patient feeling. Patient may describe that such as tightness in the chest, shortness of breath, problems with air in or air out. Objective dyspnea can be observed by the doctor while examining. What we can see, it can be intermittent speech. When during the conversation, patient need to stop for the few seconds to take air, then continue conversation. Tachypnea: if respiration rate more than 30 per minute, of course, it's a sign of objective dyspnea. Any respiration rhythm disorder, when breathing becomes irregular. If you can see participation of accessory muscles in respiration. Cyanosis appearance or bluish and observed in case of respiratory, cardiovascular, central nervous diseases. So now you know that subjective dyspnea, we can get this information after questioning, and objective dyspnea after patient examination. Next classification of pathological dyspnea according to time experience. Dyspnea can be constant, remains for the long time at rest, and increases in case of physical exertion. Severe form of respiratory heart failure. In case of these diseases, patient has constant dyspnea. Periodic dyspnea arises in severe diseases and disappearing during recovery. Pneumonia, pleurisy with effusion, obstructive bronchitis, pneuma, and hydrothorax. And last time, paroxysmal dyspnea or asphyxia. It is severe sudden attack of shortness of breath caused by the sharp stimulation of the respiratory center. Next classification of pathological dyspnea according to the violation of respiratory cycle can be inspiratory dyspnea, when patient has problem with inhalation difficulties. It can be expiratory dyspnea, disorder with exhalation, or it can be mixed. Inspiratory dyspnea is so typical for cardiovascular diseases, expiratory for bronchial asthma or other respiratory diseases. And as you know, these two systems are working together. So in problem in diseases of respiratory and cardiovascular system, dyspnea can be mixed. Next main symptom is a cough. Defensive reflex designed to clear and protect respiratory tract. There are two types of cough. It can be dry, unproductive without sputum expectoration, and cough can be moist or productive with sputum expectoration. Cough is a main symptom, so we should identify and give more question about cough. We need to ask patient about amount of sputum expectorated during 1 feed or during the entire day. We should ask patient about time of the day during sputum expectorated more, position of the body which may provoke the sputum expectoration. Of course, we can ask about character of sputum, kind of sputum, mucus, serous or purulent, consistency of sputum, viscous, fluid, foamy, and color of the sputum, white, green, bloody, and sometimes odor of sputum. Hemoptysis. Hemoptysis is expectoration of blood with sputum during the cough from the respiratory tract. If blood expectoration is more than 200 ml per day, we will name it pulmonary bleeding. Requires surgical intervention and, of course, emergency care. Now you can see hemoptysis. And next main symptom is pain in the chest. To compare pain in the chest lungs, respiratory origin, or heart origin, we should know the main sign. First of all, respiratory pain in the chest doesn't have clear localization, so patient cannot show you exactly the place. Pain in the chest in case of respiratory disease doesn't have air radiation. Spreading is absent in this case. Pain often has prickly character, prickly sensation, and associated with breathing, coughing, and sneezing. So patient will tell you that pain increases when he is breathing more deeper or coughing, or when he changes the body position. And pain long remains after recovery. So it was the main the main characteristic of pain in the chest in case of respiratory diseases. Now, nursing care in case of breathing problems. Standard of nursing care: physical examination, diagnostic studies. It must be collection of sputum specimen for laboratory studies, and preparation for the instrumental examination. Diagnosing, determination of the patient problems. So, of course, first of all, it will be violation of breathing. It must be psychological support, ventilation of the room, air in the room, breathing and coughing exercises to help sputum expectoration, and postural drainage also. Oxygen administration, pharmacological therapy, and we will talk about inhalative method of drug administration, patient education, and first aid in case of emergency, or pre-doctor, pre-hospital care. More detail about all of those interventions we will talk in next lecture. So thank you for attention.